So before we discuss ACE inhibitors, it's worth quickly going through the RAS pathway so we can visualise how these medications work. RAS just stands for renin-angiotensin-aldosterone system, but we will discuss the aldosterone system and medications in a different video. This system just regulates blood pressure and fluid balance. So firstly, the liver produces a peptide endocrine hormone called angiotensinogen, which circulates in the plasma. Now, angiotensinogen just floats around doing not a lot. It's a precursor, so it needs to be cleaved or activated. This is done by the enzyme renin, which is released by the kidneys. The kidneys release this because the juxtaglomerular cells have sensed a decrease in renal perfusion, so they need that blood pressure to increase to sort this out. So this cleaves angiotensinogen into angiotensin-1, a decapeptide. This again is a precursor and needs to be converted into angiotensin-2, an octapeptide. This is made possible by the release of ACE, produced primarily by the surface of the endothelium in the lungs. When angiotensin-2 is produced, this is able to act directly on small arterioles and constrict them, therefore increasing blood pressure. It also triggers the adrenal glands to release aldosterone and retain sodium and water. So if we knock this ACE enzyme out, none of this happens and we get a nice decrease in blood pressure. Brilliant. So ACE inhibitors are used in the following: hypertension, heart failure, post-myocardial infarction, renal complications caused by diabetes mellitus. These have an effect of protecting the kidneys, so are often used for this purpose. They may also improve insulin sensitivity and slow the progression of diabetic neuropathy. So when are they not to be used, or when do we need to be cautious? They're not to be used in pregnancy. Breastfeeding information is limited, so best not to use them. Hereditary or idiopathic angioedema, hyperkalemia when the levels of the potassium in the serum is too high, renal impairment, hyponatremia and hypovolemia, and unstable heart failure. This is to be used under specialist supervision only. So on to some drug interactions now. Angiotensin-2 receptor blockers. You don't want to use two drugs affecting this pathway if possible. It increases the risk of hypokalemia, hypotension and renal impairment. Diuretics, care is needed here. Both together they can cause a very rapid fall in blood pressure in someone who is volume depleted. Halopurinol increases the risk of leukopenia and hypersensitivity reactions. NSAIDs increase the risk of renal impairment and can cancel out a hypertensive effect. This includes medications such as ibuprofen and naproxen. Antacids can decrease absorption, and ACE inhibitors can increase plasma lithium levels. Some of the most common side effects are listed on the screen there. I won't read them all out. Angioedema just means a swelling of the eyes, lips and tongue, and can compromise the airway. Now, I just wanted to mention a bit about the cough and how that comes about. It's due to the blocking of the ACE enzyme. Now, normally ACE will break down bradykinin and substance P. If it's blocked, these substances start to build up in the lungs, causing bronchoconstriction, so some patients experience a dry, tickly cough. This won't get better with time, so these patients are often switched to an angiotensin-2 blocker or an ARB instead, as ACE will still be circulating as normal. So for monitoring, renal function and serum electrolytes before treatment starts, and then check again 1 to 2 weeks after starting and after each dose increase, then just annually. And blood pressure, of course, a blood pressure check 4 weeks after each dose adjustment. Now, what advice can we give the patients about their new medication? Because these medications block the effects of angiotensin-2-mediated aldosterone secretion by the adrenal gland, they can cause hyperkalemia, which is why the patient is monitored. So, it's worth advising the patient to avoid low-sodium salt preparations, which are available, containing potassium instead, such as low salt. The very first dose of this medication should be taken at night, as it can cause a rapid reduction in blood pressure and cause dizziness and possibly falls. And lastly, if the patient at any point develops diarrhea and vomiting, they should maintain fluid intake and stop the ACE inhibitor for 1 to 2 days until they recover. This is due to the risk of a reversible rise in serum urea and creatinine, which can increase risk of renal failure. So that's it. Thank you everyone for watching. And if there's any topics you want me to cover, just let me know in the comments.